Next speaker will be Gurnari from University Tor Vergata, and he will speak about the applicability of IPSS molecular in aplastic anemia and PNH. Please, Carmelo, up to you.
Good morning, everybody. Thank you for selecting my abstract entitled Molecular International Prognostic Scoring System, IPSS-M, in Myelodysplastic syndrome arising from prior aplastic anemia and paroxysmal nocturnal hemoglobinuria diagnosis. So I would like to start with this riddle, which is not any riddle, it's Damashek's riddle, Blood 1967, which says, what do aplastic anemia, paroxysmal nocturnal hemoglobinuria, and hypoplastic leukemia have in common? Well, it's still a matter of controversy, but you can see in the bubbles there and how the bubble overlap that there are some shadowlands in this clinical spectrum from bone marrow failure syndrome and aplastic anemia as the prototypical example to hypocellular MDS, MDS as we all know it, and AML. It is indeed still now an unclear continuum because aplastic anemia patients exhibit a high rate of late clonal complication when compared to normal population. Post-aplastic anemia and MDS and AML, so MN in general, have a serious prognosis, lacking predictive risk factors, and the increased use of EPAG that has recently been proposed to be added to the immunosuppressive treatment has increased the rumors about like the problems of clonal evolution in these patients. So the last 3 years, I made up my luggage and I went to the United States in the Cleveland Clinic. And despite all the social, political, and cultural shock I have to face, which I summarize here in this picture, we were able to accrue a big cohort of 1,008 patients with aplastic anemia and PNH treated at 4 international institutions who are pioneer in the treatment of these patients to study the clinical molecular feature of progression and the issue of clonal evolution. So here are summarized like so the characteristic of this patient at evolution, which we recently published in JCO, 94 patients, majority males. They had a median time to progression of 4.5 years and majority were MDS. Overall survival was 40% at 5 years and was impacted by the number of blasts at MN progression, more or less than 5. Molecular features were very peculiar with a specific signature related to chromosome 7 and some genes, in particular ASXL1, RUNX1, ZPP1, as you can appreciate from the waterfall plot on your right. And when we then analyze cross-sectionally this patient from onset to evolution, we saw that not only molecular lesion, but also immune privileged lesion like HLA and PGA were shaping the clonal trajectory of this patient, with the patient harboring myeloid driver hits at onset of the bone marrow failure syndrome having the higher risk of progression. And then 2022 opened a new era in MDS because in the recognition of the growing role of the somatic mutation, specifically in MDS, a highly heterogeneous disorder, there was a urge to implement with the molecular information the prior scheme normally used to prognosticate the outcomes of such patient, and therefore in July 2022 the IPSS-M was released. So the main clinical problem that the MDS community faced was, is this applicable in any situation? So we thought, given this possibility that of study studying the secondary to aplastic anemia cases to apply the IPSS-M in this instance. So we selected 69 patients that had the SMDS phenotype with complete clinical genomic information for our from our large data set, and studied IPSS-M with regards to outcome prediction, both overall and leukemia-free survival. These are the clinical features: median age 63 years, majority males, and despite low median bone marrow blast, patient fell in the high-risk category, so more than 3.5 of IPSS-R, according to Pipe-Stocker Blood 2016. And this was because they harbored cytogenetically defined poor risk subtypes, in particular chromosome 7 abnormalities. Overall, almost 50% of patients received disease-modifying treatment with HMA or transplant or both. Leukemia progression was registered in 14% of cases, and with a median follow-up of 55 months, the overall survival and leukemia-free survival achieved 44 and 42%. With an applied IPSS-M. And what happened? As you can see from this heat map, when comparing 5 to 5, because IPSS-M has 6 instead of 5 categories, so we merged in order for comparison purposes, moderate, low, and high. 55% of cases were re-stratified, and 63% were up, and 37% were downstage. So this is important because a non-negligible fraction of patients was also downstaged. So let's play the find the difference game. These differences were explained by the different number of mutations that were accounted for in the new IPSS-M. Indeed, 77% of SMDS patients harbor at least one IPSS-M mutation, with 43% harboring at least 2. When trying to understand if there was an incremental benefit and for the clinical applicability of this new tool, we performed statistics, RLC statistics, and we saw that there was an implement when using IPSS-M, but still limited. So we wanted to go further. So we explore whether the IPSS-M could be used to predict the overall and leukemia-free survival also in such cases by taking advantage of an internal cohort of 1,200 patients. But problem emerged. The problem is that a lot of these patients were treated with disease-modifying treatment. And we know also from the original study publication in New England Journal of Medicine that the C index for treated case is significantly reduced because we introduce a bias, which is a disease-modifying treatment, as the word says, that is something that alters the natural history of the disease. Therefore, we applied a propensity score matching by using age, gender, and treatment type received as relevant covariates to reduce any possible confounder or bias in our analysis. What we saw is that the overall and leukemia-free survival outcomes of secondary to aplastic anemia cases parallel those observed in the de novo group when of course, comparing patients in each similar categories. In conclusion, we applied for the first time the new IPSS-M in a real-world cohort of the secondary to aplastic anemia MDS, showing, of course, a potential for an incremental, despite limited benefit, for prognostication of outcome in such instance. The survival was similar in cases with de novo and secondary to aplastic anemia cases, and what we can speculate is that the limited incremental benefit is derived by the fact that such patients have a genomic makeup that is significantly associated with the specific cytogenetic features which are already accounted for in IPSS-R, specifically and chiefly the lesion 7, and therefore this impact on outcome is somehow independent from the accompanying remaining mutations that are now accounted for the IPSS-M. I would like to thank you everybody for the attention. Thank you.
Thank you, Carmelo. Questions from the audience? I have one, Carmelo. Any interactions between the treatment that was given during the aplastic anemia or PNH and the subsequent events, such as clonal evolution, occurring of mutations?
So I didn't show this, but in the publication that I mentioned of our prior study, we showed that patients who didn't respond to the conventional immunosuppressive treatment were those who progressed the most, who have like the highest risk of progressing. And this was also, we found a signal also in multivariate analysis.
And there was an association between, just to refresh my mind, between the progression and which mutations?
So the mutation were those typically of what we call the chromosome 7 signature,
Okay.
which were ASXL1, ZBP1, and RUNX1
Okay.
in particular, which we had mentioned many times now. No, it seems like these are somehow associated to condition where bone marrow is subjected to a lot of stress and inflammation, and aplastic anemia, of course, is like somehow a prototypical model to study that.
Thank you. Please go on.
So coming back to the challenge of doing next generation sequencing in our myeloid leukemias, I mean, when I look at the IPSS-M, I was really a little bit scared because 31 genes, this is much more than we are doing with NGS for AML. And I think this is another challenge. For the clinical practice, I think this is really difficult to do this in a routine way in these patients. But what I would like to know from you is, so what we ask ourselves the question, if we do have young patients with aplastic anemia or PNH, is there anything we can do, we can screen for to exactly predict their outcome with regard to the therapy they get or the risk of developing a secondary MDS? What would you recommend in these cases? Most of these cases have a normal karyotype, and I think this is not representative because bone marrow aspiration is frustrating in these cases.
Thank you for the question. It's indeed a problem, and I think it's important to nowadays follow this patient with routine NGS from the beginning in order to identify those patients that are higher risk of developing secondary clonal complication, which we showed are those who already at the beginning harbor those kind of molecular signature, even without chromosomal 7 abnormality. So we had patients with ASXL1, RUNX1 mutation that then developed mutation with the same not only gene mutation but exactly the same mutation that then represented the bulk of the disease at the fully blown onset of secondary myeloid neoplasm. So I think those patients are the ones that maybe if younger, if like there is availability of a donor, might be intensified with an allograft.
Thank you. Thank you very much, Carmelo.
Thank you very much, everybody. I would like to add, this is like such a nice, it's really a pleasure to be here. And I would like to thank my mentor, Professor Vosa, for organizing this meeting. Thank you very much.
Thank you, Carmelo.